We are live.
Good evening, everyone. I welcome you all to today's iFocus online session. We are running in the 455th lecture. Today is the 6th refractive surgery module. And today we have Dr. Ritika Sachdev ma'am as a speaker, who's going to teach us about wavefront analysis and the application in refractive surgery. Welcome, ma'am.
Thank you, Kritika.
Moderator for today's session is Dr. Tulika Chauhan, ma'am. After finishing her MBBS and MS from MG Medical College, she finished her fellowship and she did her research fellowship in cornea and external eye disease from Massachusetts Eye and Ear Infirmary, Harvard University. She did a clinical and research fellowship in cornea and refractive surgery from Steen Eye Institute, University of California at Los Angeles. She attained research scholar in cornea and glaucoma service from University of Mainz, Germany. Ma'am attained certification in management of low vision from LVP Eye Institute, Hyderabad. Currently, ma'am is a senior consultant in cornea, external eye disease, cataract and refractive services at Center for Sight Eye Institute, New Delhi. She's a fellowship program coordinator at Center for Sight Eye Institute, a wonderful mentor Center for Sight can have. And she has numerous publications in prestigious national and international journals. She's an editor and reviewer of AIOS, ARVO Journal, TVST, CJO, DJO, DOS Times, Curious. She is involved with clinical research and trials as well. Welcome, ma'am. And over to you, Dr. Tulika ma'am, for introduction of our chairperson and speaker.
Thank you, Kritika. Thank you very much. And I'm glad to welcome our chairperson, Dr. Syed Maaz Moeddin. He's MS from Osmania Medical College, DNB and FRCS, and FRCS in the Royal College of Glasgow. Fellowship from the very prestigious institute, LV Prasad Eye Hospital. Currently is a consultant refractive surgeon at Center for Sight, Hyderabad. He performed almost more than 20,000 carotid refractive surgery and is practicing for almost 17 years. He's the first surgeon to perform no blade, no flap smile procedure in South India. Numerous publications in PubMed index journals, multiple presentations at national and international conferences, and awards and recognition. We all know that he's got a Best Poster Award in ACRS 2017, Gold Medal at IRCR, and C.K. Reshmi Endowment Award. So welcome, sir. We are glad to have you here. Our speaker, we all know her she's very popular name in the cornea, and Dr. Ritika Sachdev. She has done her MBBS from Lady Harding Medical College and her MS from from Mansi. She has done her cornea specialization from RP Center Ames, and she's presently a director of medical services at Center for Sight Group of Eye Hospital. There are numerous awards to her name, which are already there. There are too many awards at this age, and this is like, amazing. Numerous publications in prestigious national and international journals. She authored almost 9 chapters in various ophthalmology textbooks, more than 100 presentations at national and international conferences, and co-investigated in FDA-approved trials and research projects. So I welcome Dr. Ritika for iFocus. So as we all know that wavefront analysis is an important diagnostic and management tool in modern day ophthalmology and optometry. So let's understand the critical aspects of aberrometry and how it is relevant in our day-to-day practice from the expert. So without further delay, may I invite Dr. Ritika Sachdev to share her expertise on wavefront analysis. Over to you, Dr. Ritika.
Thank you, Dr. Tulika. Am I audible?
Yes, ma'am. Yes, ma'am.
Yes.
So, good evening to everyone. I'll be talking about an exciting and at the onset, it sounds confusing, topic of wavefront in refractive surgery. The reason I have this picture, which seems unrelated, is that when you hear a song, you kind of enjoy the melody. But when you look at the notes, you don't understand anything. So wavefront is something similar for a refractive surgeon. If used well, it gives beautiful outcomes in terms of visual quality. But when you start and look at the fundamentals of it, it may seem as complicated as the notes. But once you learn to read it, you will be able to create the song. So this is really what the talk will take you through. It'll cover the basics of wavefront technology to allow you to hear the song that the wavefront sings. We will cover how it has been incorporated in Excimer lasers and how it has modified ablation profiles. And interspersed in all this would be case examples and clinical applications. So before we start, I think we don't have the ability to interact, but I'll still be asking questions and answering them, perhaps myself, or having the panel answer them. So Wavefront actually doesn't come to us from ophthalmology. It comes to us from astronomy, because when you had telescopes and you wanted to decipher the image of the stars, the light that comes in undergoes aberrations along the way because it comes to the atmosphere, and there are certain aberrations which are intrinsic to the mega optics of telescopes. So in order to create clearer visions of the stars above, we had Wavefront help us. Now, those of you who are reading the news, it is in the news today that the James Webb Telescope has just taken a beautiful picture of a very distant galaxy. And it is the James Webb Telescope, which is millions of kilometers away from the Earth, that is the masterpiece in wavefront technology. This telescope actually has 18 mirrors that have been joined to create one mirror. And this mirror is about 6.5 meters. The greater the size of the mirror, the more is the visual signal that it can gather. This is an infrared telescope, and it uses wavefront to really give you better quality images. What has been actually photographed by this James Webb Telescope and shared by NASA less than 24 hours from today has been this distant galaxy. Now, we earlier had an image of this distant galaxy from the Hubble telescope, which is one of the most popular names most of us have heard. Now, if you look at this image, and now let's see what the James Webb telescope has shown. So there is a huge difference between this image and this image. This image allows you to see the kind of pattern that the dust has, and the cosmic dust plays a very important role in the development of galaxies. So this is the resolution that the wavefront technology has imparted to the James Webb Telescope, so much so that they've been able to come up with a name called the Sombrero Galaxy for this galaxy, because it looks like the sombrero Mexican hat. So from the galaxies, these are very common images that we see in ophthalmology, which are that of images or of the Xenon letter. And you can see that a blurred image, which has more wavefront aberration, to a clear image, is what a refractive surgeon wants to generate, because a refractive surgeon is aiming for the eagle vision, so popularly called near perfect or super perfect vision. The wavefront in ophthalmology actually got incorporated in the year 1973. So from astronomy to ophthalmology was in the year 1973. So let's come to really understand what wavefront is and why do we need it as eye surgeons. The eye is a refractive surface. Fortunately or unfortunately, it's not perfect. So when you have a wave moving into a refractive surface like the eye, you can plot, say, you can plot all spatial points at the same time to create a waveform. Now, once this waveform moves through the optical surface, if it is a perfect optical surface or a refractive surface, there will be no distortion in the waveform. It will come to a precise focus. However, because surfaces are often imperfect, there will be aberrations introduced and the waveform will get distorted. This distortion or this deviation from the normal is what we measure when we measure wavefront aberrations. So there are ways to basically quantify the aberrations by seeing the deviation from the actual wavefront shape from that what would have been ideal, right? So this deviation is then measured as the wavefront aberration. We have all been told that all the halos and glares of refractive and multifocal patients worsen at night. That's because larger the pupil, more is the aberration. Now, how do we measure? Is basically by the deviation can be measured by throwing in a waveform and seeing how much it gets deviated, which is the ray tracing method, ingoing tracing, or we see that the reflection from the retina, and once it comes out and you sense it over your sensors, what is the deviation, which is the Hartmann-Shack aberrometer or the principle that you have on outgoing ray tracing, right? But basically, you have a waveform moving or transversing a refractive or an optical system, either while going in or while going out. And in this distance, the aberrations induced are then measured. Once you measure it, the tougher part is how do you depict it, right? And this is where a Nobel laureate, Frits Zernike, who's a Dutch mathematician, actually created the Zernike polynomials. You have measured the aberration of a waveform. Now, to depict it, there is a method that Zernike called the Zernike polynomials. There is another method that is the Fourier analysis. The Fourier analysis uses sine wave forms, and that sine wave form is presented in a manner to basically summate the deviation. What we use more commonly is the Zernike polynomial. The Zernike polynomials breaks down the wavefront deviation into various orders of aberration. The most common lower order aberration that we are dealing with as day to day, even the opticians are dealing with, is the second order aberration, which is astigmatism and defocus. Defocus is basically myopia and hyperopia, the spherical error. This is what the glasses correct, and this is what standard LASIK also corrected. We saw that the quality of the image goes down due to aberrations other than this. So glasses alone cannot correct all the aberrations. This is where the role of higher order aberration comes in. The higher order aberrations, though there are numerous of them, you can group them into one collective identity called higher order aberrations and measure the total amount. And there are at least 3 specific higher order aberrations that are very important to us as cataract and refractive surgeons, which include the coma, the trefoil, as well as the spherical aberrations. So we will discuss aberrations in totality and these 3 aberrations of higher order aberrations in greater detail. Like I said, the sphere and the cylinder contribute to 90% of your blur. Okay, so if you use glasses, 90% of your visual quality, you will be more than able to compensate that blur. The higher order aberrations, which account for the remaining blur, 98.2% of it comes from the anterior corneal surface, and therefore the importance to the refractive and the corneal surgeon. I had mentioned that Zernike and Fourier are the 2 ways to depicting it. And it is also important when you depict the aberrations, you also mention the size of the pupil, because the greater the pupil size, the greater will be the aberrations. So there is a pupil size dependency on it. Classically, whenever higher order aberrations are mentioned, they are mentioned at 6 mm of pupil because it is relevant as regards the optical zone, as the pupillary size, as well as this IOL optic size. So 6 mm is something that is used very significantly. As you can see here, the aberrations have increased significantly at 6 mm. This is a patient of keratoconus. And as the size of the pupil goes down, the aberrations, though they are there, they are not distorting the quality of the image. So the thing that we understand from this is night vision is something that is where aberrations play a crucial role. And pupilloplasty techniques or senile meiosis limits the impact of aberrations. When we have to measure aberrations through the Zernike, we still need certain numbers or certain forms to communicate it. Now you see here, you have a perfect wavefront, which is depicted in blue. And if you have aberrations introduced, the waveform will deviate. There'll be a zigzag, right? So that red depicts the aberrated wavefront. It may be higher, lower, but it is still going to be depicted in a positive form. In order to depict it in a positive form, you square it and then you root mean square it, right? So as to take into account the magnitude. So the RMS value is therefore calculated. The deviation is in microns. So the unit here of the higher order aberrations, RMS value is micron. Some people translate it into diopters also. 2 other things that we are very familiar with is point spread function and modulation transfer function. You see here the point spread function of how a point image gets distorted due to the play of the aberrations within the optical system of the eye. Now, the main focus for us is the higher order aberrations. I again like to repeat that this is the second order aberration that the spectacle is treating and standard LASIK is treating. And these are the higher order aberrations, which are Zernike polynomial 3, 4, and above. Now, like I said, higher order aberrations classically come from the anterior surface of the cornea. And whenever there is irregularity or an irregular distribution of power, these aberrations come more into play. Let's look at this example. This example has a higher power superiorly, lower power inferiorly, right? You can reverse it and such a patient would have keratoconus, right? So this is again an aberration. Here, this is a classic case of a myopic LASIK done, because when you do myopic LASIK, you reduce the power of the central cornea. So again, this is going to introduce an aberration. Let's study the kinds of aberrations that we are looking at in these two cases. The most common aberration that we've all heard of is spherical aberration. Spherical aberration is responsible for glare. So I'm starting with an image of the glare. But how does spherical aberration really come in? Spherical aberration comes into an optical system when the peripheral rays and the central rays are focused at different points. If the peripheral rays are focused in front of the central rays, like you're seeing in this image, there is a difference in the focus of both focal points. And this difference in microns represents a positive spherical aberration. A positive spherical aberration is periphery focused in front. A negative spherical aberration is that the peripheral rays are focused behind. So, spherical aberration is innate in our corneas. I think I've already displayed it. So this is a study which was done in corneas across Europe, actually, in Caucasians. And the mean value of the anterior corneal spherical aberration was seen to be about plus 0.27 microns. This is at 6 mm, again, the pupil size being important. At 6 mm, the mean value is plus 0.27. There are people who have less or more. This is the mean value. Can any of you help with where does this figure actually translate into exactly plus 0.27 microns? Kanika, Garvita, any idea? Okay, so this is the exact spherical aberration that is taken into the J&J aspheric IOL, right? So the techness actually came up with the negative spherical aberration to counter the positive spherical aberration in the cornea to come up with a less aberration in the overall optical system, because the positive spherical aberration of the cornea gets negated by the negative spherical aberration of the IOL or the lens. Now let's look at why does our cornea have spherical aberration. If you have periphery and central rays coming to a perfect focus, you will see a clear image. But if this focus gets elongated due to the spherical aberration, you will get what is depth of focus. So depth of focus is a positive play of an aberration, which may compromise your image quality. The image quality that is compromised in terms of contrast by spherical aberration, the upside is that you've gotten a depth of focus. So the positive spherical aberration of the cornea, which is a mean value of 0.27 microns, is what is imparting this depth of focus. Now, what happens when you do a myopic LASIK? A myopic LASIK will make the central cornea flatter, right? So the peripheral rays will then come to a focus more in front because the central cornea has become flatter. So the spherical aberration, which was positive to begin with, will increase much more. So myopic LASIK, because the central cornea is becoming flatter, will increase spherical aberration, positive spherical aberration. So you see here, this is the fourth order aberration on the Zernike, Z4, spherical aberration. This is a post-myopic standard LASIK scan of a traditional LASIK. And you see that there is a tremendous increase in the positive spherical aberration. This is a earlier LASIK when wavefront optimized and other aspheric profiles were not as available. So a normal human cornea gets of more positive spherical aberration from a myopic treatment. What happens after a hyperopic treatment is that you're making the center steeper. So such a cornea, the central rays will come to a focus before the peripheral rays. So you are inducing a negative spherical aberration. Because spherical aberration is a naturally occurring aberration, our brain has a great propensity to adapt to it to the tune of up to 0.35 near normal, and up to 0.6 is a tolerance of spherical aberration. So you can see that the tolerance of spherical aberration is greater than other higher order aberrations. And because the tolerance of spherical aberrations is more, it lends its role in presbyopic LASIK, where you try to increase the aberration profile of the eye to give depth of focus. And it also is being adopted in extended depth of focus IOLs. IOLs are outside the purview of today's talk, but you must know the spherical aberrations plays a role in presbyopic as well as IOLs, giving you greater depth of focus. This is the hyperopic LASIK that I was mentioning, because you're creating more power in the center. So the disparity in focus between the center and the peripheral rays will give you a negative spherical aberration. Now coming to another aberration, which is the third order aberration or coma, which basically comes into play more when you have different powers in the central part of the cornea. So the image passing through the pupil will have different magnifications. You will have two different powers through which the central image is processed. And this will create a comet-like appearance. When you see a light, you see here, this is the comet-like appearance. So this is the coma higher order aberration. You see the image on the left side, the less power and the more power, again, creating difference in power, more in center. This is actually a form of irregular astigmatism, which causes an aberration, which manifests as coma. This difference or deviation is vertical, so this will give you a vertical coma. If this was horizontal, it would have given you a horizontal coma. This distribution also has more power on top, so it's a positive vertical coma. If this distribution had more power below, it would have been a negative vertical coma. So more power below is classically seen in keratoconus because keratoconus has inferior steepening. So the classic wavefront aberrations of keratoconus is a negative vertical coma, right? Now, this is what a coma does to the patient. It's again, it's more central. So it disrupts your vision in the central part. So it gives you a comet-like tail to a point. Another third order aberration is the trefoil. Unlike the coma, this is more peripheral. This is a regular alternate variation of the magnification of the meridia in the corneal periphery. So classically, you see this. What can you think of that happens in the eye, which leads to this is an arcade, right? There are incisions which cause this peripheral distortion. So this is what a trefoil leads to in terms of the starburst, right? You can see the image, you can imagine the arcade and the visual outcome is starbursts. But these visual disturbances are more peripheral. So sometimes the peripheral disturbances may appear less disturbing. But it's not one aberration that is coming into play at a time. Every system will have a combination of aberrations, right? One may stand out more in certain cases. This is what the trefoil looks like in point spread function. Trefoil, you can actually, from the name of the trifolium leaf from which trefoil actually comes, is you can remember the archetype of this aberration, and this is what it leads to, the starburst phenomena. Now, a short quiz. This is, like I said, the anterior surface of the cornea is responsible for aberration. Now, you can see this profile of the anterior surface. From what we have learned so far, what kind of aberrations do you think, and what do you think is first the diagnosis? And following the diagnosis, what are the kind of aberrations that this patient will show up with? So this is the part where we put the song into place from the...
Ma'am, attempt, Kanika.
Yeah.
Ma'am, this looks like a post-myopic LASIK treated patient with a little decentered ablation profile, probably, and it is giving a positive spherical aberration, but it is intersecting the pupil as well. So there will be other mixed aberrations too, I guess.
So that's a near perfect answer. It is a slightly decentered myopic ablation. Because a myopic ablation is there, it will introduce spherical aberration, which will be positive because it's myopic. Because it is a decentered ablation, remember in the center, if you have two power areas coming into play, what is the aberration you introduce is the comma. It's more horizontal, right, than a vertical deviation. So you will be introducing, it's actually a diagonal. So you'll be having horizontal plus vertical comma coming into play here, right? So look at the wavefront profile and the image because it's a combination. So the image is distorted. You have a great amount of positive spherical aberration and a greater horizontal comma than a vertical comma because the decentration was more horizontal than it was vertical, right? So you can actually, from the knowledge of how a wavefront error is caused, predict the kind of wavefront profile or match it from. So now let's look at this one. Can you come up with a diagnosis from the simple wavefront profile that is here? What is the largest wavefront error here?
Ma'am,
It is,
what?
yes,
Negative.
negative vertical comma, which is the classic diagnostic of
Keratoconus or
keratoconus, right? So vertical comma is a negative form, is classic inferior cone of keratoconus. Now we are going to link wavefront to refractive surgery. So refractive surgery actually blossomed with the Excimer laser. And the Excimer laser was first discovered in the US Air Force Laboratory in 1981. And it was an Indian in the IBM lab in 1983 that Srinivasan, who used the Excimer laser as a perfect cutting tool. And he has written IBM here because it was in the IBM lab. What is the IBM written on? What is the background of the IBM?
it's a hair follicle.
Yes, it is a human hair. So that is how fine the laser was. It, of course, got patented by Srinivasan and got used in the eye by Trokel et al. And so this is what the Excimer laser did. It was a photoablative laser, and it could create very precise cuts or ablations, right? So you can see here, if you can write IBM so precisely, you will be able to create patterns that will remove or manage the wavefront aberrations because they also require great degree of precision. So the marriage of the Excimer laser with the aberrometer created the wavefront optics that were used in refractive surgery. So when you use the Excimer laser, there is minimal collateral damage. So if you see the hair, the remaining parts have no burn or no damage. So therefore, it was a perfect tool to etch the cornea. Now, how we etched the cornea was earlier traditional LASIK was very simple that, okay, we just have to flatten the cornea to get rid of myopia and steepen the central cornea to get a hyperopic correction. And the lasers focused on this. So the traditional non-customized ablation profile was the conventional treatment. We upgraded our knowledge basis wavefront to come up with customized profile. When you come up with customized profile, you can then correct or optimize the wavefront errors in the eye. But before we could do that, the Excimer laser itself had to evolve. This is just a short representation of the evolution of the Excimer laser, because without this, the wavefront correction would not have come in. So the earliest Excimer lasers used a very broad beam, large diameter Excimer beam. These had slower repetition rates, and they were giving, a higher amount of area was being corrected, and therefore you were creating uneven abrasion patterns because the larger the spot or the beam, the less precise you can make the correction or less customized that you can make it. This then moved to narrower beams with scanning slit, which improved the smoothness of the correction. And it also allowed you to then create transition zones and move to larger treatment zones. What we use now are the flying spot lasers, which are much smaller in diameter. Because they are smaller, they have to work faster. So you have a very, very high repetition rate. And because you are creating small changes, you are able to therefore create precise, and you are able to do the wavefront correction. But because these lasers have to fire at the right spot, you need a tracking mechanism to ensure that the flying spot laser also is able to deliver precise outcomes. So the evolution of the delivery of the laser was accompanied by iris registration and eye tracking to ensure that the precise delivery led to accurate outcomes. Once all this was possible, we then moved to the wavefront guided laser profiles. Now, wavefront optimized and wavefront guided depend on the knowledge of the aberrations of the eye, but they are different. Why are they different? It is because of this, that when you are ablating the cornea, the rays of the excimer that meet the cornea in the central portion are more circular, and they fall in a more oblong pattern in the periphery, leading to loss of fluence. So there is an aberration that gets induced due to difference in the delivery of the excimer laser in the periphery. This aberration that these aberrations that are introduced by the excimer laser affect the final visual quality of refractive surgery, which is why you have many earlier cases of LASIK say that we had so much glare, so much halos, etc. So now let's come to the simple concept of understanding the 4 different treatments. Conventional treatment. Conventional treatment did not use the higher order aberration knowledge. It said that the second order aberration, which is defocus and astigmatism, which is being corrected by your glasses, is what we seek to correct. When they corrected it with the excimer laser, in the process, it induced aberrations itself, right? So this was the conventional treatment. Now, when we understood that the excimer laser is treating your spectacle power but inducing aberrations, we said that aberrations are bad and we should try and treat them after mapping them. So once a person has aberrations, let us try and give near perfect quality of vision and not only remove the refractive error, but also the aberrations that are intrinsic to the eye. So came the wavefront customized or wavefront guided treatment, that we will not just remove the second order, we will remove your higher order aberrations, right? But the point is that higher order aberrations were not significant in all cases. And we were able to also use some aberrations like the spherical aberration for an advantage like depth of focus. And whenever you correct more, you use more tissue, right? You add the complexity of using more tissue. So a realization came that do we need to correct the baseline aberrations of the eye, or should we just refine the refractive procedure such that we remove the glass power without inducing the aberrations that we are inducing? So what does Wavefront Optimize do? Wavefront Optimize says that, okay, you have certain baseline aberrations. I want to do a LASIK on you to remove your glass power, but I should not induce or give you aberrations. So Wavefront Optimized basically compensates for the induced aberrations of conventional LASIK so that the quality of vision post LASIK is not deteriorated. I hope that's clear. So wavefront customized, intrinsic also treated, induced also treated, and spectacle power also treated. Wavefront optimized says the intrinsic aberrations, if not significant, don't need to be treated. I will just compensate for the induced and treat your spectacle power, and conventional treats only spectacle power. Now, there are certain cases where the intrinsic aberrations are higher, which we depict as RMS. Remember, RMS was a cumulative magnitude of the higher order aberrations. So if the RMS value is more than 0.35, or some people take 0.4 microns, then only does wavefront guided possibly has a slightly significant improvement in quality of vision over wavefront optimized. But if the existing RMS HOAs are less than 0.3, then wavefront optimized is good enough. Topography guided, which has become very popular with the introduction of Contoura. LASIK was also introduced because, remember, when we're doing wavefront, we are generally looking at the aberration profile of the whole optical system. because the waveform is transversing the eye and then being measured, or coming out of the eye and then being measured. And we know that the anterior corneal surface is the most important landmark that contributes to most of the aberrations. So topography guided basically focuses more on the anterior corneal surface rather than focusing on the wavefront of the entire eye. And this is very important in cases which have irregular corneas or decentered ablation. This you should know from the point of view, and I think maybe covered in future. Like I said, when you're correcting more, it's not the Mullinan formula is a generic formula which is based on the diopter of correction. So the greater ablation depth comes with greater optical zone. In fact, it's a square function and the greater dioptric power. But also keep in mind that when you add wavefront customization, you will be end up using more microns per diopter. So we have evolved now in Excimer laser from broad mean to flying spot, and because of the flying spot, giving customized treatments to our patients. So this really was the wavefront journey of refractive surgery that I wanted to cover with you. Thank you for your attention. And I'll also like to acknowledge Dr. Mahipal for really creating the platform on which Dr. Santosh built iFocus and iFocus Online. Dr. Rashmin, who pioneered this journey along with Dr. Santosh, and Dr. Tulika for now putting it together in the present avatar, and everyone at Team CFS. Thank you.
Thank you, Dr. Ritika. It was wonderful. It was a wonderful revision for all of us, I believe. And Dr. Mars would agree with me. And we were like totally glued to your presentation, if you ask me. Because we are scared of, most of us are very scared of aberrometry when we first introduced to it. And when someone will teach us this way, then I think it become easier for us. Thank you very much.
Thank you. So can I ask a question to hopefully from Garvita and Kanika and Kritika?
And Dr. Yes.
So we understood that myopic LASIK and hyperopic LASIK are introducing spherical aberrations, right? So from what you've understood, if you have to do an IOL selection, right, of a person, because this is very common now. If somebody has come who has had myopic LASIK, right, what IOL would be preferred, and also for hyperopic LASIK? I'll break down the question for you. Myopic LASIK, what is the spherical aberration that you've introduced?
Positive spherical.
Positive. So what do you want to give in the IOL?
Negative or aspheric IOL.
Negative or aspheric IOL, right? So, and the greatest negative spherical aberration is there with J&J, because they went to minus 0.27, and because others had to do something different, they went to minus 0.20, saying that let's keep a little bit behind. So it's simple, myopic LASIK, because they have positive spherical aberration, you go for the aspheric IOL. What about hyperopic LASIK? What have we introduced as a spherical aberration?
Using negative spherical aberration.
So what should we give in the IOL?
I think
Aspheric or positive.
So if we give aspheric normally has negative also with it, right? So the traditional IOLs, which had the positive spherical aberration, actually are useful for hyperopic LASIK to make them aberration neutral, because this is a case where you give a negative spherical aberration to the cornea, which normally has positive, right? So you can go for the traditional lenses of the spherical IOLs. Right? So these are common situations that you will encounter with the growing practice of refractive surgery. I think we're going to give a generation, Dr. Mars, we're going to give a generation of new ophthalmologists that struggle of post-refractive surgery, IOL selection and power calculation, which maybe our generation did not have to face much of. But your generation definitely will.
The IOL with positive spherical aberration, which I can think over my head, is Envista by Bosch and Lomb.
Yeah, you have sensor and all these are positive spherical aberration. Yes.
Positive spherical aberration. So, Dr. Ritika, the way you highlighted the practical applications of wavefront technology in improving patient outcomes were truly enlightening. Thank you for that. Now, a simple question, say a DNB student is asked in the examination, 3 scenarios where a wavefront would benefit a patient while doing LASIK. say you have a patient who wants to undergo a LASIK procedure, what are, say, 1, 2, or 3 scenarios where doing a wavefront analysis and a wavefront guided treatment would be helpful for a patient? So what would be your 3 kinds of patient where you would definitely do a wavefront?
Okay, so basically obviously if there's higher intrinsic RMS HOAs, you
Correct.
would want to do wavefront
Correct.
customized treatment. There
Correct.
are patients who have irregular corneas,
Correct.
particularly those with keratoconus, where you may
Right.
want to go for a trek,
Right.
right?
Correct.
And you have patients who had residual refractive error prior to previous
Right.
injuries,
Excellent.
which
Yes.
again have some aberrations which are significant in the eye. So these
Correct.
are cases that you will go for. So virgin eyes with higher intrinsic when you get a,
Good.
and the corneas being more irregular and cases being more complicated. These are the
Great.
3 buckets of cases which I would definitely consider for wavefront. Um,
Correct.
that's really
Yeah,
the
that's absolutely right. And the same thing which we all use in our practice. Now, to flip the question around, in which patients you would not be doing a wavefront after doing a wavefront test?
see the wavefront optimized treatments are very useful. So
Useful. No, I'm
and
the corneal optimized wavefront where you would not be doing after doing a wavefront
yeah,
test.
so I basically feel if the RMS value is not too high again, then the patient unnecessarily doesn't need more
Correct.
tissue. Also, if you're doing a borderline corneal thickness where you
Correct.
feel that the cornea is, borderline and maintaining the residual stromal bed is
Correct.
going to be an issue, then you will
Correct.
definitely have to compromise on your wish list because the tissue is a finite. And in
Correct.
these cases, you can even think of phakic IOL options.
Correct.
If you feel that the intrinsic, HOA is high, and
Correct.
with wavefront, if
Yeah.
the dioptric power is less and you can, or the corneal thickness is,
So
borderline.
basically, with wavefront optimized, there are no contraindications as such,
No,
apart
no.
from the corneal thickness. But
Yes.
wavefront guided or topography associated, suppose if the astigmatism is not corresponding to the refractive error and the ones which we are getting, say in terms of magnitude, if it is the difference is more than 1 diopter, or if the axis and cylinder is more than there's a variation of more than 15 degrees, we might kind of do a wavefront and not do it on the
Yeah,
patient.
no. In fact, now I think the latest Eyes that is being launched is going to take wavefront to, they plan to take it to nearly a greater array of patients. Let's see, it's still not fully
The
launched
ray tracing.
commercially,
Right.
but they are now trying to claim that it's going to be the eagle vision and we should not stop at 6.6. And wavefront is the only way to get there.
But this kind of claims, we have been hearing it since
I
a
think
long,
it's a matter
long
of realizing
times.
that 6 is good, and it's
Correct.
actually looking at wavefront to correct uh, existing problems in vision. Patients who are post-RK, patients who even multifocal, like if you look at the wavefront of a person who has a bad ocular surface, and you realize that there is a lot of HOA, keeping
Correct.
away from multifocal IOLs. So understanding that there is an intrinsic aberrations, know it, either correct it or don't increase it. That
Correct.
is really the fundamental mantra of understanding aberration. And you can increase aberrations when you do a refractive surgery or when you put a multifocal IOL. So when you are doing something where you can increase aberrations, it is very important to know what you're dealing with in the first place. If it's too high, then your patient is going to be unhappy forever. And if it is too high, there are ways to treat it also with the topography guided and the wavefront treatments that have come in through Excimer laser. So that is the second bit that as ophthalmologists we can now achieve.
And as you have rightly pointed out, finding the source of the aberration is also very important. So if, as you rightly said, if it's a dry eye, a simple treatment by lubricating would definitely improve the quality of vision. If it is by an early nuclear sclerosis, you can just do a simple cataract surgery and get the higher order aberrations corrected.
I think this is a very important point that you brought out, the dysfunctional lens syndrome that we don't talk about much in India. In fact, one of our ophthalmologists who we felt had minimal cataract kept insisting he needed cataract surgery. And he had tremendous improvement in the quality of the vision. And we realized that we had not done his wavefront analysis. So perhaps the aberrations that had come into the lens through the nuclear sclerosis or through the Sennen's acuity that we normally do were not visible. And the dysfunctional lens syndrome is basically deterioration in the quality of the vision in early or cataracts that are not as visible on the slit lamp, but they still warrant a removal of the cataract for improvement in quality of vision. And these will come across when you see that the lenticular aberrations are high.
Correct.
Right?
So we have a question from our DNB student, which Dr. Ritika already covered, but we will
Dr.
clarify
Tulika can
again.
elaborate on that.
Sorry, the question which is sent to us? It's sent to on my on this another link actually. The question is, how does pupil size affect the wavefront aberrometry result? This is a question from DNB.
Yeah, so the pupil size, the smaller the pupil, the lesser is the wavefront aberration. The larger the pupil, the greater is the wavefront aberration that you will pick up. That's why you pick it up at 6 mm of pupil. That is why when you do a pupilloplasty in patients of even keratoconus, their quality of vision improves. That's why when you use a pinhole, the quality of vision improves. So with increasing pupil size, aberration increases. And with decreasing pupil size, aberrations reduce. For DNB students, this is very practical. Use of pinhole, use of pupilloplasty. Also, when you have patients who are older who have senile meiosis, they're normally happier with multifocal IOLs. The glares and the halos don't show up. And also, because of night vision, the problems are there because the pupil size is larger. So LASIK patients therefore complain of more problem in night, right? So this is all an interplay of the size of the pupil.
So I have a question regarding when you are dealing with regressions or you are planning the enhancement, then what is the role of aberrometry in such cases? Because obviously patient expectations are higher in such cases.
Yeah, so it depends on if it's extremely decentered or there are a lot of the aberrations. You will do a customized either topo. See, this I think would be outside the purview of the DNB, but when there is a regression, you have to ensure that you do multiple things. You have to ensure that the spectacle power is stable, the epithelial remodeling has happened, and if it is a simple not too many and how many aberrations are at play, you can use wavefront customized. But again, if the aberration is decentered, you may obviously look for a topo-guided treatment because it gives better results because it regularizes the cornea significantly. So this would be the take-home message at the DNB level from my side.
Another question which everybody feels confused about: which method is better, ray tracing versus Hartmann-Shack? Dr. Mars, can we have your opinion on that? The question is, which method is better? Yeah.
So normally, the one which we are using is the ray tracing method, right? Hello? Yeah.
Yes.
Yeah. So ray tracing, because in ray tracing, the advantage which I feel is that you could also know the source of the aberration. Okay, whether it's corneal or whether it's internal or whether it's lenticular. And I think that is a very important point whenever I would be planning a treatment. Because say, as you have done a LASIK, say 10 years back, and the patient is coming to you after 10 years, the aberrations, yes, from the cornea, you can know it, but it could be dysfunctional lenticular too, as Dr. Ritika has pointed out. So I would say a ray tracing would be a better way of planning treatment as such.
Yeah. So here I want to add one point, which I'm facing in my clinic in day-to-day point, the pinhole. I think it's the biggest enemy of a refractive surgeon because patient expect that everything would be pinhole. And the first thing I tell to my patient that pinhole is not normal. In your day-to-day life, you will not have a pinhole vision, not even with the glasses you are having it. So once they go for the pinhole, they said, okay, everything was clear. But with the glasses, it is not. So this is the thing, we have to set real expectations for the patient, because pinhole will just remove all the possible aberrations, what the question Dr. Ritika answered just a minute before. So yeah, this is the thing which I'm facing with patients sometimes. So just mentioning it, that
I think
whole aberrations are
Kanika just
completely correct.
expanded the role of all refractive surgeons, that can we utilize these corrections to correct only the to regularize aberrations. Oh, she's added irregular corneas and not removing glasses but aberrations. So Kanika, this is what you
Yeah.
do in terms of keratoconus, where but if you have the ability and the tissue, then you might as well in the process remove glasses. But this is exactly what we do in keratoconus. We try to improve quality of vision by regularizing the surface, be it even if you're using topography as an indicator, you're basically doing it to distribute power, and the redistribution of power reduces the aberrations, right? So this is exactly what you do in patients of keratoconus, that you reduce the aberrations and may reduce the refractive power, but the primary aim is to reduce the aberrations. And that is done in irregular corneas, because if the aberrations are too low, they don't affect your quality of vision enough to warrant a treatment, right?
So, okay, this, I don't think so. This question which I'm asking, it is for the DNB. So I think we'll pass it, because I was just, you mentioned the keratoconus. I was just thinking ki topo guided and the wavefront guided both we do to regularize, but I think it is the
Yeah.
question not for DNB. Yeah.
I was actually trying to take Wavefront to a level that the DNP is able to understand. That's why I kept
Yeah.
a little simple,
Yeah.
because I remember
Yeah.
getting interested in Wavefront in my PG days, but it was so complicated that I was able to understand Wavefront only after a cornea fellowship. Though it has
Yeah.
nothing so directly related to being a corneal surgeon, it is a theoretical concept. And as cataract surgeons, also Wavefront does have now greater
Yes.
implications. But I think that will be covered somewhat in the new gen IOLs that will be covered in the
Yes,
cat.
of course. So, Dr. Ritika, Dr. Mars, if you want to add anything to this, we'll conclude the talk then.
I think Dr. Ritika has covered almost everything, and it was very lucid and very clear, and we were able to find a clinical correlation to the physics of wavefront. So I thank Dr. Ritika for the wonderful presentation, and also a big thank you to all the audience who are listening to this. Thank you all. Thank you very much. Do you want to add anything to this, Dr. Ritika?
Oh, thank you. Thank you, everyone.
Thank you for taking all the effort, Dr. Ritika. It was a wonderful talk, very, very explanative, and we all liked it. Thank you very much for joining us.
And thank you, Dr. Garvita, Kritika, and all the support team. Thank you, everyone. Bye-bye. Good night.
Thank
Good
you.
night, sir. Good night.
Thank you,
Thank you, ma'am.
Sayed. Thank you. Thank you. Thank you. Good.